I'm Matt McClanahan, so I'm an osteopathic physician. I work over at the center, well, it's called Integrative Medicine Associates now, formerly the Center for Integrative Medicine. We are with Memorial Hospital and such. And as an osteopathic physician, I don't know if you guys know what DOs are versus MDs. A DO is trained identically to an MD, with the exception that we're also trained in manual or anatomical diagnosis and treatment. That kind of sounds like manual work or manipulation, and it is. So chiropractors broke off of us 100 years ago and decided they wanted to do just the manual part of that and not the rest of the physician part. And so that's, if I had 5 seconds in an elevator, I'm an MD combined with a chiropractor. The nuance is actually a little bit more subtle, and we've got some good tools to use and work that in. All DOs are trained in manual medicine, and about 80% don't do it. So a lot of you probably have DOs or specialists that you've seen. We're in every specialty. There's been DO surgeon generals before. Anyway, so there's the quickie on DOs. We're everywhere. Most of us don't do manual work. I still do. And pain gets to be tricky sometimes. As probably a lot of you in the room, or some of you in the room, have had pain or know people with pain. We all who are presenting up here treat pain. Some of you might do that too. I know that's true for who's here. And it can be really tricky, especially when it's persistent pain. And that's a word we're going to use. A lot of times we've said chronic pain, and we're going to explain why we're going to do our best to try to shift the language to things like persistent pain and why that's important, why language is important in how we talk about these things. But that's really hard to treat, and we're not very good at it. As a medical community, alternative pain treatments, body work of various kinds, acupuncture, nutritional approaches, Reiki, prayer, whatever, meditation. We do a lot of these things here. These are all really important. And sometimes that helps. And when it helps, great. And those people get better, and then they don't come to workshops like this. And when it doesn't, that's kind of what we're interested in. Because every specialty in medicine and all these alternative practitioners have patients that it's just hard. And it's really frustrating. And it's frustrating for us, and it's frustrating for the people who hurt all the time. So pain matters. These are the concerns, as it concerns us. These are the issues here at hand. And the pain dilemma, right? We've got a few funny little pictures in here of maybe painful things happening or about to happen. Yes, so I've kind of articulated this. Pain is just this funny thing that we've had for a long time. Actually, Jason's going to get into this in the history of pain. But here's how we doctors have treated pain, right? With medications. And that really works sometimes. For acute tissue damage, opiate medications work very well if you've had your hand slammed in the door or broken a bone or burned yourself or something post-operative. These work really well in the short term for tissue damage, and they work really horribly in the chronic sense. Pain is the most common presenting symptom across the board, and I'm talking about things like migraines and irritable bowel and fibromyalgia as well. When you look at those, in addition to like my back hurts or my knee hurts, that's the most common presenting complaint across the whole board. It's a third of why anybody goes to the doctor at all. Low back pain is the second most common reason people just go to their primary care doctor. This is really expensive, so $2,000 for every person in the United States. That's a lot for pain every year. It's the most common cause of disability is some form of pain, followed by anxiety and depression, which is sort of interesting. We'll get to that later. And we eat a lot of the world's opiates in the U.S. Maybe we're just a really painful country or something, I don't know, but we consume a lot of the world's opiates. And just from the standpoint of prevalence, that's the total number of people. Chronic pain, actually, or persistent pain rather, is more than heart disease, cancer, stroke, and diabetes combined in terms of numbers. Now, some people say we don't know how many people are actually diabetic, but regardless, that's a lot of people. Tennessee we're doing real great with this. I guess we're a really painful state. We have the second highest rate of prescription and controlled substances, right? And so HC is hydrocodone, Vicodin. There's a little pointer. Can you see the pointer right now? Yeah, there you go. 21 pills of oxycodone and 22 pills of Xanax for every person over the age of 12 in the state. Right? That's quite a lot of medication, very strong medication. Overdose deaths are now greater than highway deaths. This is a 210% increase. In Tennessee, we're beating the national average. That's great. Go Tennessee. Neonatal abstinence syndrome, this is when little babies, right when they're born, they withdraw from opiates because they're not getting moms anymore. They do really well. It messes up their brain and their breathing. Can be a serious cause of disability later in their life. You can read a lot of these things. Crimes are up. Now, this is interesting. Like opioids are now the primary substance of abuse over alcohol. I had a slide in my other talk last night. It shows a little graph that prescription opiates keep going up and up and up every year, whereas things like cocaine and heroin are kind of like flatlined. We're staying stable, and that's a low thing, and that's good. We don't want those things in our society either, but prescription opioid abuse increases every year. Thanks, right? Thanks, Doc. That's me. So what have we done for this? Well, we've done a lot of MRIs and more procedures and injections and surgeries, and certainly written lots more opiates. But what have we gotten for this? Well, we've gotten more disability. The rate is higher, not just the number, the rate. We have not gotten any more improvements, which is sort of the opposite of what we're aiming for. And we're spending more money, right? And this is like chronic pain, just as from a population standpoint, again, we've increased 10% the population in this decade, right? It's 6 years later, so that's probably gone up again, assumingly. And 122% increase in chronic pain over that decade we just got through. So we're not doing something right? And this is that page. So there you go. You can see that this is just like climbing every year, and that's weird. So how's that working for you? You know, we get all Dr. Phil on this. This is actually a great question that will come back later when we talk about pain. How's it working for you? The things you've done, the things we've all done, is it working? And often it's not, but love that guy, kind of. So I want to kind of start to make the case that like maybe pain is a little bit something other than we presumed it to be, right? We assume that like when I hit my elbow on the podium here and take some skin off and my elbow hurts and I can see that I've taken some skin off, it's like, oh, that's my elbow that's hurting. It's coming from the elbow. Well, we're going to kind of present an alternate universe where maybe that's not just the case, that it's only the elbow that's hurting in this thing and pain is coming from the elbow, right? That tissue damage and pain may not be the same thing, even though this is kind of getting into that quiz we were talking about, some of these questions. So this is demolition derby drivers, right? They did a study back in 2005 looking at 40 drivers, about 1,500 collisions at fairly high speeds, right? And only 3 of these drivers ever developed chronic or persistent neck symptoms. That's kind of weird, right? Because almost everybody who gets into an accident has neck pain or has back pain or has some pain, right? No matter what the accident is, I have people coming in even just wanting to get checked out. They're like, I don't have any pain yet, but I just want to make sure, right? And that's interesting. So that's sort of an assumption that we have, right? This is one very interesting. We hear about these things all the time, people playing through broken bones on the sports field or whatever. This lady had shrapnel in her body and pulled all her comrades to safety in Afghanistan, I think it was. And it's very interesting in the interview and in the article, it talks about her. She didn't feel the pain of the shrapnel in her body. It wasn't that she was ignoring it or limping along and grinding her teeth. She just did not feel it. Okay, and then she pulled her buddies to safety, and then she stopped, and then she felt horrific pain after the situation was over, and she saved her friends. But that's real interesting. She had severe tissue damage, but no pain, right? Here's one where it's very interesting. It's a great case out of Britain where a construction worker jumped off a scaffolding, put his foot down, nail went right through it, in horrific pain. He's writhing around. They took him to the emergency room. And they were loading him up on pain medications, and they shot an X-ray, and the nail had gone right between his toes. And immediately his pain turned off, and he was like, "Oh, okay." And so they wrote this study up. This is actually a separate X-ray, but they wrote this study up to make the case that like you can have pain and no damage. We've even heard of things, and Jason will talk about this, like phantom limb pain. I don't know if you've ever heard of that. He'll kind of get into this. This is when a limb has been traumatically taken off or surgically removed, and there's still some sensation involved. Well, that's kind of impossible from the standpoint of tissue. We'll talk about why that phenomenon exists. Here's another one. This is called a spondylolisthesis. Gosh, sorry about that. Maybe that little cart moved since last night. Anyway, grade 4. This is an asymptomatic, so no symptoms. Grade 4 spondylolisthesis. Yes, excellent. So spines should line up very nice like this. See these little things are the disc. These are the bones right here. And a nice straight line, a little curve in here. That's actually normal too. And this is a pregnant lady who was getting an MRI for something else. And they detected that this doesn't look right like this, where that line is. That's the yellow line sign we have in medicine, meaning bad. Sometimes it's the red arrow sign. This vertebrae is slipping off. This is the L5 slipping off the first sacral vertebrae. And this is where the spinal cord goes, right through that tight little spot. And the spinal cord actually stops up here, but a lot of the little nerve endings and nerve roots come through here. She had no pain, no back pain, nothing going into her legs, into her buttocks, or into her feet, right? Tissue damage, no pain. So from an X-ray, from an MRI, this is where it gets sort of interesting. We can't actually tell what's going on here. I am missing a slide here that actually shows age-predicted findings on MRI. And here's the thing. It's very interesting that the older you get, well, what happens to everyone? We start to get some gray hair. We start to get a few more wrinkles. Might put on a few more pounds we didn't want to. But what also happens to our... What's that?
We get shorter.
And get shorter, of course. Well, part of this is just a normal aging process. Now, the spine changes on an MRI, and Jason will get into this much more. I have another slide that does talk about this. This is normal. Disc bulges, arthritis of the spine, facet degeneration, if you've heard that term, that's a joint in the lumbar spine. These things are normal, okay? And by the time you're 70 years old, it's about 80 to 90% of people have arthritis in the spine. Upwards of 70% have disc bulges, right? But I thought disc bulges are the thing that causes your back pain, right? We get a back pain, we get an MRI from, or an x-ray from me or whatever, or the chiropractor, and we see the disc bulge, that space getting narrow, and we say, aha, your back pain, you have this narrowed space, that's the cause. And that actually is not, that's not supported in the literature, okay? Now, that said, disc bulges, facet arthropathy, these things can cause pain, okay? They can cause a pain experience, they can cause damage. Sometimes people need surgeries, okay? And probably some of you have had some back surgeries in here and other surgeries for pain. And that's no problem, okay? There is not, doesn't mean that all surgeries are bad or anything. But the presumption that all pain comes from what's on the MRI is false, okay? And that's why it's impossible to tell who would be the one doing this, okay? Playing on a scooter or riding around on a tennis court, I guess. So the predictors of low back pain disability, this is where this gets interesting. So that in mind, structural findings are very weak, okay? And if we go to Unum and we talk about the people with low back pain and that are disabled from that, those sorts of findings are very weak, okay? The amount of disc bulges, because there are people on disability with no disc bulges, and they have disability from back pain, right? The things that are very strong, and this is across the literature, multiple studies support this. Psychosocial factors are very strong predictors of low back pain disability. And I mean, your socioeconomic status. I was listening to a guy yesterday we ran into. The biggest predictive factor of your health or not, I don't know if you guys know what it is. It is your zip code. Right. Where you live is the biggest predictive factor of your health overall. And that has to do with multiple societal things, financial, some safety factors, that kind of thing. It involves water, food deserts, access to a good, nutritious food and exercise, that kind of thing. But these other things, psychiatric comorbidities, abuse in childhood, we'll kind of get back to that. Your beliefs about pain, what it is, what it isn't, how you cope with things. These are all extremely important as to what causes pain. Do you guys know the most predictive factor of if you're going to go on disability for your back? You say family? No, family history. That's a great guess, actually.
What did you say, the predictor?
The biggest predictive factor of whether you might be disabled from back pain. Trauma, okay. These are all great things. These are all things that I thought too.
Other people you know?
Other people you know, okay. The biggest predictive factor, do you like your job? Number one, at Unum, like if you go over there and ask them who, like the biggest predictive factor of people having disability from these things is they hate their job. And they're not faking. These are not people that like are weak and just want to get a free dime from the company or from the government. But low job satisfaction is extremely predictive, the most predictive, in fact, of whether you're going to be disabled from your back pain. So let's look at lumbar surgeries, right? These are the things where the carpenter's going, line things back up. Whether or not, maybe you had these disc bulges, well, they would have done surgery. They wouldn't have done surgery on a normal spine, so you probably had something on this MRI, right? And sometimes we talk about failed backs. And this is really an interesting study from back in the mid-90s. This has been repeated, actually. They looked at who fails and why do people fail, okay? And failure was determined as a repeat surgery, continued pain, continued disability, need for continued opiate medications or more epidural injections and things. And as they looked at the study population, it was the same group of surgeons. These people, was a good broad population, men and women, blacks, whites, browns, other colors of people. And same surgeries, same MRI findings, same collection of MRI findings. And they were just looking back to see who failed these surgeries, okay? And they ruled out a lot of things like smoking status or obesity or just gender. If you're women, are you tougher or weaker or whatever? They ruled these out, and nothing like really stuck significantly to say, man, this is not predictive. Looking at a person who's coming in my office, who is going to have a successful surgery or not? That's always the question, right? Surgeons want to know who's going to be successful. And the biggest thing they found was childhood trauma. And that's a really interesting thing, because what in the world does childhood trauma have to do with the carpentry of a back surgery, right? Well, everything. But it's very interesting that has probably very little to do with the disc itself, or the capacity of the surgeon to do this sort of thing. They looked at these 5 right here: physical, sexual abuse, they had an emotional abuse or neglect, abandonment by your primary caregiver, or drug abuse by the primary caregiver. They looked at these 5 only. You're kind of recognizing this on that other survey that you had, that ACE survey, that stands for Adverse Childhood Experiences Survey. We will get into that a little bit later. And here's the table. I'm going to blow it up for you. So this is the number of the risk factors that they had down here that they found. If you had 0 risk factors, well, you had a 95% chance of having a successful surgery. That's pretty good. Good enough for statistical significance, good enough to get an A, good enough for me to take that risk, right? If there was a 95% chance that I would have a successful surgery. Now, it actually starts to drop off pretty precipitously to the point that if you had 3 of these or more, you had only a 15% chance of survival. Or not survival, of success. I don't know that there were many deaths here. Sorry. 85% chance of failing your surgery. And I don't know if you guys are making up the adding up the factors in your mind for yourself. That's fine. If you knew that this was what was going to happen to you, if you were going to go into surgery, would you take these odds? 15% chance of success. Right. I wouldn't either. And how many of our surgeons have asked this? Right. How many of any of your doctors have asked this? Other than other than a select few of us who have been exposed to this sort of thing. Yeah, that's really interesting. So this is where it gets interesting that I probably won't put this up in my office, but this is, some people have proposed this statement that this is actually like, I don't know what you guys think about that. Just settle on that one a little bit. It sounds like sort of ridiculous that back pain is the mind's way of diverting attention from emotional damage. But my back just hurts when I bend it, right? My back hurts because I fell down the stairs 5 years ago, or I had a football injury, or that car crash, or since my pregnancy, or whatever. And this is where it gets interesting. We actually see a lot of other things related to this. I'm actually going to click on this right now. I have not done this on this thing yet. So bear with me. Hang on. We're going to talk about something called the ACE study here. I really hope this works. If it doesn't, we'll just move right along. Huh. Well, moving right along. Peculiar. Let's see if, come on now. Sorry, guys. So pay attention to that, and this will come up later. As will all those graphs where it just shows this increasing number of bars and the bars get taller, that will come up over and over again. It'll come up one more time actually. Sorry, over and over again is a little exaggeration. If you look at the data on these, on the ACE study and things like for cancer or COPD or any number of things, including pain or alcoholism or all that, it's just this, we call it a dose-response relationship. As your ACE score goes up, so does the disease prevalence, okay? And you've taken your ACE score now, and that's certainly some like kind of private information here. But this is where you look at this and start to see like what's been going on in my life. How is this a little bit more complicated than we thought? And then we start to see that a number of studies associate these other things, things like fibromyalgia, migraines, interstitial cystitis, pelvic pain, IBS, a whole host of other things. These are just the ones from these particular studies that are associated directly with victimization in your life of some kind, abuse, these traumas, okay? Well, and so now for the kicker, and who knows what's happening here. I just love this bizarre picture. I don't even know what's about to happen or what's happening. We have the best health care on earth, right? Right? So what are we missing here? Maybe it's these ACEs or something, but like I thought we're really good at this stuff, right? And we're getting better and we understand more than our caveman ancestors and these primitive peoples before, right? Maybe it's just all these things, harder work or Obamacare or something that is making us so sick now. Or maybe we're not doing the right kinds of injections, or maybe as a manual worker I need another workshop. I just haven't had that one workshop. It's this part of the fascia, or it's that part of exercise prescription that I've gotten through yet, right? And this is what I was running through over and over with myself. Is like, why can't I help people with this? And that's where the manual medicine, alternative medicine, and well, this is where alternative medicine comes in and says, we're going to save the day. You need hormones. You need to eliminate gluten. It's fungus, and it's everywhere, and you can't escape it. Good luck. Here's a lot of supplements for you forever. These are fine, and sometimes those things help, and they turn it around right like that. And many other times they help for a little while or help a little bit, and the rest of this pain experience, it continues. And that's what we're interested in here. And I wonder maybe if we have a blind spot, right? You start to see this thing. You start to see that ACE study video. The first time I saw that was within the last 2 years, right? And I'm a physician. I've been a physician for a while now, over 6 years. And so like this is, for me to just hear that 2 years ago, that's pretty impactful. They talked about 440,000 people they've used. The original ACE study was 17,000 people. We'll show some data on that later. But I wonder if this is a piece of why these people start to look and sound so similar, right? And this is where it gets interesting, right? I don't know if you've ever colored in a pain diagram or a pain map for yourself or seen this for someone else. And you come in and say, where do you hurt? And it's sort of like, I hurt everywhere, frequently, all the time, and it's this and that area. And it just, boy, what is this, right? So I want to talk about a quick case. I'm wrapping up this part of my talk here. This is a lady who wanted to call herself Pain Jane. That was her pseudonym. I allowed her to choose her name. So Pain Jane. She was in her early 30s. She came to see me earlier in the spring. Had low back pain for about 12 years. It started after her first pregnancy at about age 20 or so. It had worsened. It had kind of hovered along and not gotten better, substantially better, but she would have these kind of peaks and valleys, like it would flare and get really bad and then kind of come back. 5 years before my visit and 2 years before my visit, she had these things. No major injuries or accidents were correlated with these flares of pain. She attributed to her job. She worked in a beauty salon, and she did nails and hair. She's bending over and doing some hard work, and so she just attributed to that. Occasionally she'd get sciatica symptoms. Her primary care had done an MRI. It was totally normal before, so none of even the age-related findings. And at age 30, the prevalence of disc bulges at age 30 is about 40%. So 40% of normal, like asymptomatic people will have a disc bulge, okay, 35, 40. That's kind of interesting. But in other lab testing, she didn't have lupus or cancer or other autoimmune disease or something significant. Treatment was the pretty standard thing, muscle relaxants, medications, this kind of deal. NSAIDs is like ibuprofen and naproxen. This APAP, I can't remember what that stands for, it's Tylenol. Okay, it's an old way to say Tylenol. She'd done chiropractic, hot baths, rest, marginal benefit on all of these things. And then she did some alternative treatment, things that in my world I don't think are alternative at all. But massage therapy, acupuncture, yoga, hypnosis even, that's kind of an interesting one. Counseling, all of which with pretty underwhelming benefits. ROS means review of systems. This is a thing we say in the medical world where we look at other systems to say, well, if you're having fevers and you're breaking out in rashes along with your back pain, maybe that's some sort of systemic disease. Or if you've lost bowel control or bladder control or something like that, or have numbness and tingling or weakness in the neurologic system, right? We ask these questions. Her review of systems, of other systems, was totally normal. No red flags for anything severe. Losing weight, that's a bad one, right? We think of metastatic cancers and that kind of thing in the spine. Those things can cause back pain too, okay? She didn't have any of those things, okay? So that's good. In her past medical history, right, she had a history that was kind of interesting for a lot of other things. And these kind of get into the review of systems a little bit, but her energy system was kind of hit for a loop. And that started along with depression in her 30s, some neck and shoulder symptomology. She had some tenderness things in her elbow and wrists, anxiousness, depression. For quite a while, actually, the anxiety and depression is about the time that the back pain started. And then she has some various other symptoms in her GI system. She had been treated for acid reflux, kind of a mix of headaches, some eczema, actually, some skin changes, kind of low libido. That kind of makes sense along with the rest of this stuff, and a lot of sleepiness and some dizziness, right? And so here's what she had. And we call these things some interesting. The ones in red are things that Pain Jane had, okay? And we start to see that various chronic pain syndromes we've identified in the past, like this is across the board in other health fields and in the rest of medicine, subspecialties and things. Some autonomic nervous system factors here, and we'll talk about these and what these mean later. What is the autonomic nervous system? And then some other symptoms that have played through here. And we call these the chronic functional syndromes. Functional meaning these aren't killing you. You don't die of migraines. Okay, you don't die of acid reflux or restless leg syndrome or something like that. These are functional in the sense that they impair your function, but they're not impairing your survival. Okay, and we can't, in a lot of these things, we can't find anything that's wrong directly. Things like with fibromyalgia, to actually get that diagnosis, we have to rule out lupus and Lyme's disease and crazy vitamin deficiencies and cancers and things. And when you meet a criteria of enough fatigue, enough depression, enough headaches and insomnia, and 11 out of 18 tender points, which is sort of, when we poke you, you're like, don't like it. You know, I wouldn't like that either. But when you have that, you meet this criteria of like, well, I guess we'll call this fibromyalgia. Right, and that's, and maybe some of you in this room have it, but that's where it gets interesting, right? We're not sure what fibromyalgia is or what causes it. And there's some speculation here and there, mitochondria and some other things, but we still haven't found the thing.
It's a symptom.
It's a symptom. Well, there you go. So fibromyalgia is a symptom, a collection of a lot of very unpleasant symptoms. But here's what we do in medicine, right? When we start to like go down one road and we're like, yes, this is where we're going, and this is what we need to do, and we apply a treatment and it doesn't work. Right, and this is what we do in the hospital all the time. When we presume it's pneumonia, but it turns out to be heart failure, we put them on antibiotics and they're not getting better. It's like, let's back up. Why are they short of breath and coughing here? Maybe they're getting fluid backed up, and we do different studies and a different approach, and we start to diurese them or something. You have to go back and rethink your diagnosis. And maybe that's what we need to do here, right? Pain. Everybody knows what pain is, right? Of course we know what pain is. It hurts when something hurts in the body. Well, maybe not, right? We actually saw those slides where pain in the body didn't hurt, and where sometimes people had no pain in the body, or no damage in the body, and there was pain. So let's talk with redefining pain, and let's start with some better neuroscience. And I'm going to lean on my friend and colleague, Dr. Jason Tarian, physical therapist. He will introduce himself.